Welcome to Dr. V's Pediatric Pulse. This is a forum for quick video reviews on common pediatric diagnoses seen in primary care. Today's topic is bronchiolitis. Bronchiolitis is a viral infection of the lower respiratory tract, primarily affecting infants and children under 2 years of age. It is most commonly caused by the Respiratory Syncytial Virus, RSV, but other viruses can also cause it, such as rhinovirus influenza. Bronchiolitis is one of the leading causes of hospitalization in children during the winter months, with the peak incidence between 2 to 6 months of age. As FNP students, you'll need to identify patients who are at high risk for severe diseases for the bronchiolitis. Infants under 6 months are at the highest risk for severe outcomes. Premature infants born before 32 weeks of gestation are more likely to experience severe bronchiolitis. Patients with underlying conditions such as asthma, cystic fibrosis, congenital heart disease, neuromuscular disorders, and immunocompromised states increase risk for complications. Environmental exposure, such as secondhand smoking, or if the child's in daycare or lives in an overcrowded place. Finally, low birth weight infants are more susceptible to severe bronchiolitis. As stated earlier, bronchiolitis due to RSV is very common under 2 years of age. Typically, they will come into the clinic with a history of fever, rhinorrhea, and worsening of respiratory distress. Early symptoms that we typically will see would be nasal congestion, mild cough, low-grade fever, and irritability. There is an increase in respiratory effort. You will see nasal flaring or grunting or tachypnea. As the disease progresses, we will hear wheezing, crackles, and increased work of breathing. Here is a recording of a 7-month-old with bronchiolitis. We will also see retraction, subcostal, intercostal, and again, as I said earlier, grunting. You will also see poor feeding, irritability, and sometimes vomiting. Cyanosis in severe cases can occur. And also you might see signs of dehydration such as sunken fontanelle. As family nurse practitioner, it's important that we identify these symptoms and differentiate it from other pediatric conditions such as asthma or pneumonia. It's really important that you assess for viral exposure and evaluate the respiratory distress carefully. As the nurse practitioner seeing this patient at the clinic, it is imperative that you can identify the red flags. This disease can escalate quickly. You need to identify respiratory distress, which is severe tachypnea and hypoxemia. You need to identify apnea, which is episodes of pauses in your breathing for greater than 20 seconds. You can see this especially in premature kids or premature infants. You will identify poor feeding and dehydration. If the infant cannot does not want to drink or doesn't want to eat, you also need to identify the altered mental status, lethargy, irritability, difficulty waking up, which suggests severe illness or hypoxia. Diagnostic testing is not recommended. We diagnose bronchiolitis due to RSV typically based on history and clinical presentation. Your PE exams, your H&P, they are key in helping you diagnose bronchiolitis due to RSV. Viral testing, blood testing, not routinely recommended. If you do order chest x-ray, typically providers do that if they're suspecting an other underlying causes such as bacterial pneumonia. When you do order chest x-ray for someone with bronchiolitis, you typically will see hyperinflation, prebronchial thickening. PCR testing such as RSV swab, a lot of clinics do that. It's not typically a routine test that American Academy of Pediatrics recommend unless you're not sure that this is RSV. It doesn't change the treatment for the patient with the bronchiolitis. I've included 2 tools here to assess for pediatric respiratory scoring tool. These tools allow you to determine whether this child is in respiratory distress as well. What are the criteria for hospitalization? Poor oral intake, apnea, O2 sat less than 90, respiratory rate of greater than 70, heart rate greater than 160 if the infant's premature or has history of chronic lung or heart disease or is immunocompromised. I like algorithms. It allows me to visualize the thinking process of how to treat or assess the patient. So this is a really great algorithm. This is based on the American Academy of Pediatrics clinical guidelines. If you go through this, you can see the thinking process of when to admit, when to treat the patient as outpatient, and when to safely send them home. So take the time to review this algorithm. And again, this is based off the American Academy of Pediatrics guidelines. Treatment today, I will focus solely on outpatient management since we are family nurse practitioner and we do not admit nor do we see take care of patients in the hospital. Supportive care is important, nasal suctioning and hydration management. Counsel the caregivers on symptom monitoring. Teach them the red flags. Teach them when to return to the clinic or when to take the child to the emergency room. Make sure that the child has adequate oral intake and hydration. Albuterol inhaler is not recommended. I have seen too oftentimes in the outpatient clinic, providers and students wanting to treat this patient's wheezing with albuterol inhalers. According to the American Academy of Pediatrics, it is not a routine care for bronchiolitis. Again, in the reference section, I have the citations for the American Academy of Pediatrics clinical guidelines for RSV. We need to teach parents signs and symptoms of complications. And we also need to teach them to monitor for worsening of symptoms. Just some clinical pearls here. Infants with severe bronchiolitis may have an increased risk for asthma. Again, counsel caretakers on increased risk for wheezing with future respiratory infections, especially those with a family history of asthma. I can't emphasize it anymore. Severe bronchiolitis is more common in premature infants and those with heart and lung disease, immunodeficiencies, and neuromuscular disorders. Last but not least, let's talk about the drug for prevention. This is called Nirsevimab. Not sure if I'm pronouncing that correctly. It is preferred for preventing RSV in infants and children because of its efficacy, duration, and convenience. It is recommended for population of infants less than 8 months, infants born to vaccinated parents, children 8 to 19 months who have chronic lung disease and severely immunocompromised or who has cystic fibrosis or of Native American and Alaskan descent. We need to prioritize the treatment for high-risk infants. If Nirsevimab is not available, they can use Pelizumab. I am so sorry, these words are hard to pronounce. And you want to administer it during the first week of life for eligible infants. Timing, administer the medication between October to March and make sure to adjust for geographical variations.